Now another thing that is going to be asked to you as a question in the exam, जिसका microbiology link होता है. Patients who are going to be having the presence of patients who are going to be having the presence of chronic hemolytic anemia, they will be having an increase in the bone marrow activity. So they will be having an increase in the RBC precursors. And these RBC precursors are highly sensitive to being damaged by a particular virus. Right? Which is the virus that we are talking about over here? The virus that we are talking about over here happens to be something like parvovirus. So parvovirus has got a property that it is going to be responsible for attacking the precursors of RBCs in the bone marrow. And when the precursors of RBCs are going to be destroyed in the bone marrow, then this is what is going to be responsible for a crisis which is given the name of aplastic crisis. It is responsible for development of a crisis in the bone marrow which is given the name of aplastic crisis. Right? So what is going to be the presentation? A patient who is going to be having a history of presence of a chronic hemolytic anemia is going to be having an infection because of which there is a sudden drop in his hemoglobin levels. Sudden drop in his hemoglobin levels. So when the hematocrit value falls down suddenly, when the hemoglobin level falls down suddenly, this is suggestive of the fact that the patient is going to be having a development of aplastic crisis. So aplastic crisis is a term that you associate with infection caused by parvovirus. That's what you need to remember over here. Yeah, this was the example of the HBH inclusions that we were making a mention of over here. Right? Next one. We are going to be talking about an example of a condition that is going to be given the name of paroxysmal nocturnal hemoglobin urea. Paroxysmal nocturnal hemoglobin urea. Over here in this kind of a condition, what you're going to be observing is that patients are going to be having a defect in a gene that is called as PIGA gene. Whenever there is going to be a PIGA gene defect, this is going to be associated with a problem of expression of CD55 and CD59. What do CD55 and CD59 do? When you go out in the sun, when you go out in the rainy weather, there is something that you take to protect yourself from the sun or from the rains, and that is your umbrella. So you are having the presence of RBCs, WBCs, and platelets. Cells are present in the blood. They are moving in the blood, and blood is also having complement proteins. So what is protecting the blood cells from the complement protein damage? These molecules, CD55, CD59. Right? So whenever there is going to be a PIGA gene defect because of which CD55 and CD59 are not there. Imagine your umbrella is blown off. छाता उड़ गया और जब छाता उड़ जाएगा, the blood cells are going to be extremely sensitive. Complement system, complement proteins, they start attacking the blood cells. Complement proteins, they start attacking the blood cells. So what is going to be happening over here is that this is going to be associated with damage to the blood cells. So finding number one, patients are going to be having a development of pancytopenia. Patients are going to be having a development of pancytopenia. PNH is associated with pancytopenia. The second thing that is going to be seen in these patients is that patients are going to be having the presence of a trouble that is going to be the development of nocturnal hemoglobin urea. Now it's easy for you to understand why nocturnal hemoglobin urea is going to take place. Whenever the activity of the complement system is going to increase, that is going to be responsible for causing RBC damage. Where are we having the complement proteins? In the blood itself. So what kind of hemolytic anemia will we expect to have over here? Extravascular or intravascular? PNH is an example of intravascular hemolytic anemia. PNH is an example of intravascular hemolytic anemia. So hota kya hai? When the patient is going to be sleeping at night when the patient is going to be sleeping, there is going to be acidosis because your respiratory rate is going to be becoming less. When respiratory rate is going to be going less, there is a very slight acidosis. Acidosis increases complement activity. So after the patient gets up, there is a slight acidosis because of which RBCs are going to get damaged. So there is going to be nocturnal hemoglobinuria. This takes place off and on, paroxysmal. So this is what is called as paroxysmal nocturnal hemoglobinuria. Now, what is going to be the other trouble that is going to be seen in the patients? The patients are going to be having the presence of, I can write over here, hemolytic anemia. Hemolytic anemia. And the patients are always at high risk of development of thrombosis. High risk of development of thrombosis. Why high risk for development of thrombosis? Because platelets are going to become dysfunctional. Platelets are going to become dysfunctional. I'll just explain that. When the patient is sleeping, Dr. Nidisa, the respiratory rate is going to go down. When respiratory rate goes down, the CO2 is going to retain in the body. When CO2 is retained in the body, that causes acidosis. So acidosis causes increase in complement activity that causes RBC damage. So pancytopenia, hemolytic anemia, and the patient is having increased thrombosis. Increased thrombosis क्यों हो जाता है? For the simple reason, when RBCs are going to get damaged, free hemoglobin is released. Free hemoglobin binds with nitric oxide. Nitric oxide is responsible for normally inhibiting platelets. अगर nitric oxide bind कर जाएगी तो platelets aggregate कर जाएंगी. And if they aggregate, they are responsible for thrombosis. Which kind of thrombosis is bad for the patient? Hepatic venous thrombosis. Why? Because this is going to be life-threatening for the patient. HVT means hepatic venous thrombosis, Budd-Chiari syndrome. Hepatic venous thrombosis, Budd-Chiari syndrome. That is going to be life-threatening for your patient. So you're asked these questions in exam. I'll just repeat the questions. PNH is the only intracorpuscular acquired cause of hemolytic anemia. It is a condition that is going to be seen in case of adults. Patients are going to be having a problem in a gene called as PIGA gene. Patients are having a problem in the CD molecules CD55 and CD59. Patients are having a classical triad, pancytopenia, hemolytic anemia, and increased risk of thrombosis, out of which hepatic venous thrombosis, which is given the name of Budd-Chiari syndrome, is going to be responsible for causing death of the patient. When the patient gets up in the morning, the first urine sample that is passed by the patient is very dark. Gradually, the urine is going to be becoming lighter in color. And after the fourth or the fifth sample, the urine is going to be having the normal yellow color as is expected. Right? So this is what is going to be seen over here in case of Budd-Chiari, in case of paroxysmal nocturnal hemoglobinuria. How are we going to be able to diagnose this condition? We are able to diagnose this condition with the help of certain types of tests. So when I'm talking about paroxysmal nocturnal hemoglobinuria, I have to look for screening test in the patient, INI-CT question, screening test in the patient. The screening test in the patient is going to be given the name of sucrose lysis test. Or the second test that I remember is acidified serum test, which is also called by the name of Ham's test. Acidified serum test or Ham's test. Sugar and acid increases activity of complement system. Sugar and acid increases the activity of complement system. So they are going to be given the name of screening tests. What is going to be the investigation of choice? Investigation of choice for this patient is flow cytometry. But there is a difference. The chemical that we are using over here for flow cytometry is given the name of flare. So this is given the name of flare flow cytometry. Flare flow cytometry. Remember, we talked about flow cytometry in case of hereditary serocytosis also. We talked about flow cytometry in case of the patients who were having the presence of chronic granulomatous disease also. But we were using different chemicals over there. In case of chronic granulomatous disease, we were using flow cytometry with the help of which kind of a dye? कौन से डाइज यूज कर रहे थे? Chronic granulomatous disease. Chronic granulomatous disease. Which dye were we using? Dihydrorhodamine. Dihydrorhodamine. In case of hereditary serocytosis, what was the chemical that we were using? Eosin 5-maleimide, EMA. And what is the chemical that we are using for PNH? Flare flow cytometry. So this was a question asked in exam. Flare flow cytometry is the investigation of choice. It is a gold standard for making a diagnosis of PNH. Gold standard for making a diagnosis of PNH. Now answering somebody's question, which somebody did make a mention of, why is it called as an example of an acquired defect? These are our examples of myeloid cells. Myeloid cells. They should proliferate normally. So myeloid cells are normal at birth. It is not a congenital condition. It's not a congenital condition. As the cells are going to multiply, as the cells are going to multiply, majority of the cells remain normal, but some cells acquire mutation. Some cells acquire mutation. These cells are normal. This cell is abnormal. Why is it abnormal? Because there is absence of CD55 and CD59 in these cells. So will I say it as an example of a congenital defect, or will I say it as an example of an acquired defect? It was not present right at the time of birth. At time of birth, it was normal. It's an example of an acquired defect. But it is involving genes, so it is a genetic defect, right? And this kind of a genetic defect, please remember, is going to be present inside the cell. So it is an example of an acquired intracorpuscular genetic defect. Intracorpuscular acquired genetic defect, which also gives you a hint. These people will be having the presence of normal cells also, abnormal cells also. They will be having normal cells also, they will be having abnormal cells also. Same person is having both the types of cells. It is given the name of biphenotypic appearance. You read it in Robbins. It's given the name of biphenotypic appearance. Biphenotypic appearance. Bi means two types of cells, normal also, abnormal also. That is why you see this is an example of a graph. Identify the investigation that is depicted in the graph. Dot scatter pattern. Dot scatter pattern. This is flow cytometry. Flow cytometry. Flow cytometry, which is a normal graph. Normal graph is like this. All cells, I told you, top right, both are positive. CD59 is also positive. CD55 is also positive. But look at the graph of a patient suffering from PNH. He is having the presence of normal cells. He is also having the presence of abnormal cells. Normal cells are present. Abnormal cells are also present. So both types of cells are present in the same person. That is what is going to be given the name of a biphenotypic appearance. ये वाले PNH वाले cells. Biphenotypic appearance. ठीक है? Pharmacology का question. We are giving two types of drugs so as to save the life of this patient. One is eculizumab and the second is pegcetacoplan. Pegcetacoplan. Right? In case you have heard it, you can revise it. If you haven't heard it, skip it. We are not here to discuss pharmacology, but the concept is important. So PNH is an example of an acquired intracorpuscular defect, PIGA gene defect, CD55-59 defect, triad of pancytopenia. So don't get confused by the fact the patient is having only a problem of RBC. It is a problem of all the three cells. Death of the patient is because of hepatic venous thrombosis. Budd-Chiari syndrome. Budd-Chiari syndrome. I hope that's clear. Talking about the next example of a condition, we have RBCs against which antibody formation is going to take place. RBCs against which antibody formation is going to take place. These RBCs are going to be given the problem that there is going to be damage caused to the RBCs. So this is an example of immune hemolytic anemia. Immune hemolytic anemia. Right? Now, depending upon what is the nature of the antibody, you are going to be having over here two types of immune hemolytic anemia. One which is given the name of warm immune hemolytic anemia. The second one which is given the name of cold immune hemolytic anemia. In case of warm immune hemolytic anemia, the nature of the antibody is very clearly written as G. It's mostly G. Uncommonly, it can be antibody which is IgA. So we always remember it in a relatively easy way. If you are Hindi speaking, you can remember G for garam. Warm means garam. Ig antibody is going to be playing a critical role. Otherwise, as young people, you remember the fact that we have a wonderful place where most of us have gone during our college times, Goa. And I don't think I need to explain why Goa is hot. G A. G and A, right? So we are going to be having a warm autoimmune hemolytic anemia in which the nature of the antibody is IgG. Why is it called as actually warm? Because of the simple fact, antibody is going to attach at 37 degrees Celsius. Antibody is going to attach at 37 degrees Celsius. ठीक है? ओके, शिवानी सिंह नहीं गए, डॉक्टर बारबी नहीं गए। बारबी तुम तो चले जाना, वहां पे बहुत सारी बारबीज मिलेंगी तुम्हें, और बारबेक्यू खाने को भी मिलेगा, ठीक है, गरम गरम। GNA, ठीक है। सो ऑन अ लाइटर नोट, सो G is what you need to remember over here, right? Now a lot of patients, we are not aware about the cause. When we do not know the cause, we call it by the name of idiopathic. So doctors have a very interesting way by which we are talking about we do not know. So we say it is idiopathic, cryptogenic। हमें जब पता नहीं होता और हम मरीज को बताना नहीं चाहते कि हमने नहीं पढ़ी किताब, हमारे सीनियर से मार्क करा के हम पास हुए हैं, then we talk about the word idiopathic, right? Another one can be because of connective tissue disorders like SLE, or patient suffering from rheumatoid arthritis, or this can be seen in case of B cell cancers. Commonest example of this B cell cancer which is asked in your exams and you need to remember as a doctor as well is CLL, right? That is what you need to remember. And then this can be also caused because of drugs. भाई ये पसंद नहीं आया जोक। ना तो पेशेंट पैथेटिक होता है, ना डॉक्टर इडियट होता है, दोनों अपने अपने सेंस के अंदर इंटेलिजेंट होते हैं। अल्फा मिथाइल डोपा एंड पेनिसिलिन, इवन दे कैन बी रिस्पॉन्सिबल फॉर कॉजिंग ऑटो इम्यून हिमोलाइटिक एनीमिया, right? That is what you need to remember. So warm autoimmune hemolytic anemia, the fundamental problem is antibodies are produced against RBCs. They will activate the complement system. They will destroy the RBCs. So that is given the name of immune hemolytic anemia. Now, when you destroy the membrane of the RBCs, some loss of membrane takes place. So RBCs are now going to be becoming spherical in shape. That's exactly what I shared with you. In case of immune hemolytic anemia, RBCs are going to become spherical in shape. In fact, I shared with you, this is a problem of, now I want you to revise. Is it a problem of adults or children? Problem of adults or children? Answer, adults. Autoimmune hemolytic anemia is problem of adults. What is going to be the typical feature of the RBCs over here? With or without central pallor? With or without central pallor? With central pallor, without central pallor, without central pallor. Such RBCs are spherical in shape. So they are going to be given the name of spherocytes. They are given the name of spherocytes. Can I detect these antibodies? Yes. Can I detect this antibodies? हाँ बिल्कुल ठीक है हिमांशु, सही बता रहे हो बिल्कुल। गोवा इज फॉर एडल्ट्स ओनली। अब इसके ज्यादा एक्सप्लेन मत करना प्लीज। दिस इज गोइंग टू बी डिटेक्टेड विद द हेल्प ऑफ Coombs टेस्ट। This is going to be detected with the help of Coombs test, right? So Coombs test positive hemolytic anemia is what is going to be associated over here, right? And these can be some of the hints which can be given in the question exam. SLE का clinical picture आपको दे सकता है exam के अंदर examiner. He can give you a clinical picture of a patient having CLL. He can give you a clinical picture of a patient having rheumatoid arthritis, or he can make a mention of a patient who has been given a drug like penicillin. Remember that MCQ that we discussed yesterday. MCQ that we discussed yesterday. Indirect Coombs test is going to be done when you detect antibodies present in the serum. Direct Coombs test when you detect the presence of antibodies present directly on the cell surface. This is a cell, you detect antibody on the cell surface directly. Direct Coombs test. When you detect antibodies which are free, this is called as indirect Coombs test. I hope you'll be able to recall now, right? So this is what you need to remember. How would you treat this condition? You simply treat the primary cause, patient is going to get better. Treat the primary cause, patient is going to be getting better. Or what you can do for these patients is that sometimes you are going to be decreasing the production of the antibodies. You decrease the production of antibodies over here, right? How can you decrease the production of antibodies? Antibodies are being produced by B cells. What are the markers for B cells? What are the markers for B cells? 19, 20, 21, 22, 23. Do we have a monoclonal antibody against CD20? Do we have a monoclonal antibody against CD20? रितु को बुलाओ, रितु को बुलाओ। वेरी गुड, रितु को बुला लिया हमने। Rituximab. So rituximab is what is going to be given for the treatment of a patient suffering from autoimmune hemolytic anemia. So you can do plasmapheresis, you can give steroids to these patients, you can give a drug like rituximab. Rituximab. Right? So this is what is going to take care of almost like 8 questions of your exam. Very, very high stuff. The second one that we talk about is cold immune hemolytic anemia. Cold immune hemolytic anemia. एंटीबॉडी ऑन सेल सरफेस, डायरेक्ट भाई, डायरेक्ट, डायरेक्टली देख लिया ना आपने एंटीबॉडी को सेल सरफेस पे, डायरेक्ट. The second one that we need to remember over here is going to be cold immune hemolytic anemia, which is going to be seen because of an antibody that is going to be IgM, right? So cool people are always going to be becoming great people. Father of the nation, with all due respect, Mahatma Gandhi. Somebody happens to be a BJP lover, he can say Modi ji. Somebody happens to be from the Congress, he can say Mr. Gandhi. हम सबके साथ हैं, सबका साथ, सबका विकास, सबका विश्वास. MG. ठीक है, मोदी जी हो सकते हैं, मिस्टर गांधी हो सकते हैं, महात्मा गांधी हो सकते हैं, जिसका आपका मन करे. ठीक. When we talk about something like Mussoorie hill station, right, that is something which is going to be related by a lot of people. बिल्कुल. और फिर से थाला को ले आया तुम, MSD को, बस बहुत बढ़िया, यही करते रहेंगे भाई. So this is going to be a lot of times because of unknown cause, that is idiopathic. Why is we are stressing on M? Why we are stressing on M, right, is because of the fact M can be for infection like mycoplasma. M can be because of infectious mononucleosis. Right? That is what you need to remember. And this is what is going to be associated with the trouble. The patient is going to be having a condition that is given the name of cold agglutinin disease. Patient is going to be having a trouble, cold agglutinin disease. So why are we calling it by the name of cold immune hemolytic anemia? Antibodies are going to be attaching with RBCs at a cold temperature. This antibody is an example of IgM antibody. An IgM antibody, as you're aware, is an example of the biggest antibody. So one antibody can bind with how many antigens? One antibody can bind with how many antigens? IgM antibody? 5. 5. 5. ठीक है? One antibody binding with 5 antigens, 5 RBCs. So it will bring the antibody for RBCs together. So RBCs are going to be appearing just like a clump. Agglutination of RBCs. Agglutination of RBCs. Right? So this is going to be given the name of cold agglutinin disease. Patient typically is having a history. He will go out in the cold weather without wearing a proper cap and a jacket. For example, nasal area, ears ka area, gloves nahi pehne. That is where he is going to be having the presence of sluggish circulation. Because of the exposure to the cold temperature, the RBCs are going to have an attachment with each other. So circulation is going to become sluggish. So that is why he is going to be having a development of a peripheral cyanosis like picture. Acrocyanosis. Fingers are going to be having a bluish discoloration, acrocyanosis. If you take the blood sample of this individual, you will have agglutination of the RBCs in the peripheral smear. Agglutination of the RBCs in the peripheral smear. So that is what is typically mentioned. History of cold temperature exposure, acrocyanosis, that you can see over here. And the peripheral smear shows you agglutination of the RBCs. So that's why it is going to be given the name of cold agglutinin disease. कोल्ड एग्लूटिन. रूले में तो हम स्टैक लाइक अपीयरेंस बोलते हैं, ऐसे ऐसे. यहाँ पे तो ऐसे ऐसे भी हो रहा है, ग्रुप भी हो रहा है, मतलब इन अ वे यू कैन से फॉर योर अंडरस्टैंडिंग. स्क्लेरोडर्मा के अंदर तो और भी मैनिफेस्टेशन होंगे ना. स्क्लेरोडर्मा के अंदर दिस इज नॉट सीन, एग्लूटिनेशन थोड़ी ना होता है. स्क्लेरोडर्मा इज बिकॉज ऑफ नॉट अ प्रॉब्लम ऑफ आरबीसी. स्क्लेरोडर्मा इज बिकॉज ऑफ वेसोस्पैज्म. रेनॉल्ड्स इज बिकॉज ऑफ वेसोस्पैज्म ना. This condition is having this also, and the peripheral smear is having agglutination of RBC. So that is how you are able to differentiate in the exam, no? Right? So this is cold agglutinin disease characterized by this important fact. Cool, cool. So that's cold autoimmune hemolytic anemia. Another one that which we need to have an idea is an exception. Exception is what you need to be familiar with, is a condition that is given the name of PCH. PCH. First humble request is read the question carefully. PCH in the exam is not to be confused with PNH. PNH is an example of a intracorpuscular cause of hemolytic anemia. PCH is an example of an extracorpuscular cause of hemolytic anemia. PCH. So PCH will stand for P for pediatric age group. P for pediatric age group. There is a child. एक्सटर्नल टेम्परेचर कोड होने के बाद भी ब्लड टेम्परेचर पेशेंट का 37 मेंटेन होगा ना, तो उसमें भी एग्लूटिनेशन होगा? नो, तब नहीं होगा. जो आरबीसीज पेरिफेरल पार्ट्स में रह जाते हैं. Only they are the ones which are going to be having a agglutination. If they come back into the central core area of the body, then they are going to separate out. तो normal रहता है फिर. So why we are going to be talking about this particular fact is, in case you wish to know about advanced concept, you have a suspicion your patient is having this. Take the blood sample of a patient, put it on a chilled slide. Take the blood sample of a patient, put it in a test tube that has been taken from a freezer. The moment you add the blood in a chilled slide, RBCs are going to be agglutinating. Now coming back to PCH, you have a pediatric age group patient who's going to be having a history of cough and cold. After cough and cold, he's going to be having a development of hematuria. PCH. Pediatric age group child who's going to be having cough and cold, khansi, jukam, URTI, he's going to be then having the development of hemolytic anemia. He's going to be having hemoglobinuria. So the name of the condition is paroxysmal pediatric cold, cough and cold, hemoglobinuria, altered color of urine. Why that takes place is because of an antibody that is seen in these patients. This antibody is going to be given the name of Donath-Landsteiner antibody. This antibody is going to be given the name of Donath-Landsteiner antibody. What's the importance of knowing about this antibody? The importance of knowing about this antibody is that this antibody is going to be associated with a typical nature. The nature of this antibody is going to be IgG. Right? So that is what you do for children these days. Na? Children who are born as the new kids, they are going to be given a lot of respect. You always put a G. Beta G kha lo, beta G pad lo. Right? Not the things that we used to face. So we used to call G only for parents. Mata Ji, Pita Ji. Now you do it for the kids. Right? So our generation, perhaps you and me can partly correlate with it, is a sandwich generation. माता जी पिताजी भी बोलते थे ऊपर वालों को, और नीचे वाला गली मोहल्ले का बच्चा मिल जाए उसको भी बेटा जी बोलते हैं. ठीक है. हाँ. जिसको ज्यादा जी बोलते हैं वो हो सकता है इसको ज्यादा जी बोलोगे तो ये काम भी ऐसे करे. जी वाले गंदे वाले. नहीं, हमारी अपनी रिस्पेक्ट है, हम अपनी इज्जत खुद ही कर लेते हैं. ठीक है. सो दिस इज गोइंग टू बी अ development of intravascular hemolytic anemia, and this kind of a intravascular hemolytic anemia is going to be seen because of exposure to cold temperature. So the condition is going to be given the name of cold hemolysin disease. It's called as cold hemolysin disease. Read the question carefully in the exam. Warm वाला जो सबका ठीक हो जाएगा, hopefully गोवा वाला गरम, and then we are talking about something like cold वाला. cold वाले में दो हैं जिसमें agglutination हो रही है, clumping हो रही है. That is what you need to remember as CAD, cold agglutinin disease, acrocyanosis. And the second one is in which exposure to the cold temperature is responsible for causing hemolysis. Right? So that is called as cold hemolysin disease. Cold hemolysin disease. What will you do for this patient? That's fairly easy. The problem of the patient is taking place because of exposure to cold temperature. So rewarming of the patients. Rewarming. If you do not expose a patient to the cold temperature, patient is going to be getting better. What the second thing which can be done for this patient, of course, you are going to be having the administration of a drug, same drug by which you can decrease antibody production. Ritu ko bulao, rituximab. So for immune hemolytic anemia, rituximab is what is going to be required. कोल्ड वाले के अंदर ऑफ कोर्स यू आर गोइंग टू बी हैविंग द डेवलपमेंट ऑफ समथिंग लाइक एक्स्ट्रावास्कुलर हेमोलिसिस. इस वाले में एग्लूटिनिन डिजीज वाले में रीवार्मिंग नॉर्मल टेम्परेचर पे डॉक्टर साहब. नॉर्मल एज इन की लेट अस से गर्म पानी में के लिए आए या फिर आपने ग्लव्स पहना दिए, सो द पेशेंट इज गोइंग टू बी गेटिंग बेटर. या रितु इज अ गुड गर्ल. रितु विल बी अ फ्रेंड फॉर बोथ ऑफ देम, इधर भी उधर भी. rituximab for both. Right? So that is what you need to remember. I hope we don't have any Ritu in the class. Please don't take it personally. Right? Then you talk about a condition which is going to be given the name of aplastic anemia. Aplastic anemia is an example of a problem. The problem from the name of the disease is not of RBCs only. It's a problem that we are going to be having for a trouble. And the trouble that is going to be seen in these patients is it is an example of a T cell disorder. It's an example of a T cell disorder. कोई बात नहीं, वो X नहीं थी यार, XX थी. फीमेल्स के अंदर ना जो क्रोमोसोम होता है वो XX होता है रघु. ठीक है, तुम्हारा जो है वो XY है. तो तुम ये मत बोलना शी वाज माय X, बोलना शी वाज माय XX. ओके, इसके आगे मत बढ़ जाना, कुछ और मतलब निकलाएगा. टी सेल डिसऑर्डर है. द टी सेल डिसऑर्डर इज गोइंग टू बी एसोसिएटेड विद अटैक ऑन द हेमाटोपोएटिक स्टेम सेल्स. It is associated with T cell attack on the hematopoietic stem cells. Right? So what is going to be seen in these patients is the patients are going to be having a trouble, which is going to be the bone marrow is going to be infiltrated by fat cells. Bone marrow is going to get infiltrated by fat cells. Now, why is this going to be important? Normally, you are having 50% of fat cells. You are having 50% of cellular component in bone marrow. Normal is 50% cells, 50% fat. But in these individuals, what you are having is the cells are not there. So all these cells are going to get replaced by fat cells. Therefore, when you are going to be looking at the tissue in the patients, what you are going to be doing over here is when you do the bone marrow aspiration, you are not able to get any cells. When you are not able to get any cells, that is going to be associated with the term dry tap. Dry tap. So what you will have to do for confirmation, you will have to perform a bone marrow biopsy. And the moment I'm going to be talking about a bone marrow biopsy, what is that going to be showing me? That is going to be showing me presence of empty areas. I hope all of you can make out these empty areas. Empty areas. White out areas. ये छोटे मोटे cells आपको बीच बीच में दिख जाएंगे. The rest of the bone marrow is going to be replaced by fat cells. So this is going to be a feature of bone marrow biopsy. So what are the questions asked in exam? Aplastic anemia is not a problem of RBCs only. It is a problem of pancytopenia. It's a problem of pancytopenia. Splenomegaly is never ever seen in these patients. Splenomegaly is never seen in these patients. Why? Because pancytopenia can be seen in case of certain types of malignancies also. Pancytopenia can be seen in certain types of cancers also. In those cancers, you are going to be having spleen size being increased. So it is a differential diagnosis of pancytopenia. Pancytopenia with splenomegaly is different. Pancytopenia without splenomegaly is different. So pancytopenia without splenomegaly. T cells are going to destroy stem cells. Stem cells. Stem cells होते हैं ना, physiology. Stem cells which will give rise to RBC, WBC, platelets. You are destroying the stem cells. So you are going to be having no RBCs, no WBCs, no platelets. Therefore, you are going to be having pancytopenia. So pancytopenia, splenomegaly is going to be absent. Their patients can be having aplastic anemia is not to be confused with the presence of aplastic crisis. वो हमने discuss किया था. Aplastic crisis is because of viral infection, parvovirus. Parvovirus. Now RBCs are having a precursor, reticulocyte. Reticulocytes have a precursor, normoblast. Normoblast has a precursor, erythroblast. Can you revise? Which cell in the RBC development is going to be having the presence of maximum erythropoietin receptors? Maximum erythropoietin receptors. CFUE. CFUE. ठीक है? So when there is going to be a destruction of stem cells, so CFUE नहीं होगा. CFUE नहीं है, so there is going to be no erythroblast. No erythroblast, that means no normoblast, that means no reticulocyte. So you are going to be remembering the fact that there is going to be a presence of reticulocytopenia. Reticulocyte count is going to be reduced in these patients. Reticulocyte count is going to be reduced in the patients. So clinically, please remember that fact. If you have a suspicion that your patient is having the presence of aplastic anemia and you find the patient is having spleen present, you are able to palpate the spleen, then your diagnosis is wrong. Spleen is never increased in aplastic anemia. You are suspecting aplastic anemia. Look at the reticulocyte count. If it is increased, your diagnosis is wrong. So it's a very important all except MCQ. All of the following are features of aplastic anemia except splenomegaly is never seen. Please remember, reticulocytopenia is going to be seen in the patient. That means retic count is always going to be decreased. Bone marrow aspiration, what is it going to show you? Aspiration, dry tap. If I'm going to be getting nothing in the aspiration, can that be confirmatory? Never. Never. So what is going to be confirmatory for the patient? Bone marrow biopsy. Bone marrow biopsy. Revise the name of the bone marrow aspiration needle, which is going to be having a side screw. Bone marrow aspiration needle having a side screw. अरे भाई काली मत दो, साला साला मत लिखो, साल्हा लिखो, साल्हा. मेरी सलाह है आपको कि साल्हा लिखें इसको, ठीक है? And then we are going to be talking about bone marrow biopsy needle, which is going to be useful for making a diagnosis. ठीक? That's what you need to remember. Please also remember the fact sometimes इस कंडीशन में क्या हो रहा है? RBC, WBC, platelets, all are being destroyed, all are being attacked. But we have a condition, dry tap दिख रहा है दीपक. We have a condition in which patients are going to be having INI-CT question. Pure red cell aplasia. Pure red cell aplasia. Only and only red cells are going to be destroyed. And this is what you see in a patient who is going to be suffering from thymoma. Pure red cell aplasia is going to be seen in a patient suffering from thymoma. INICET 2023's question. What is the other paraneoplastic syndrome that you get in a patient having thymoma? Very good. Curly Medicos already answered it. Myasthenia gravis. Myasthenia gravis. Right? So this is what you need to remember for the purpose of your exam question. Then we are talking about a condition that is going to be given the name of microangiopathic hemolytic anemia. Microangiopathic hemolytic anemia is a problem. This is a blood vessel. It is going to be having the deposition of platelets over here. And between the platelets, you are having the presence of fibrin strands. So there is formation of thrombi. PRCA is seen with thymoma, not with aplastic anemia. So RBCs are going to be present over here. RBCs are present over here normally. But when RBCs pass through this area, RBCs are going to become fragmented. RBCs are going to become fragmented. These RBCs are going to be given a special name. They are called as schistocytes. These RBCs are going to be given the name of schistocytes. So what is the reason for schistocytes? You are having the presence of damage in the blood vessel, angiopathic hemolytic anemia. Angio means vessel, problem in the blood vessel, because of which hemolytic anemia takes place. This can be causing involvement of small vessels, or this can be causing involvement of big vessels. So if it is going to cause involvement of small vessels, I will call it by the name of microangiopathic hemolytic anemia. Small vessels are affected. Microangiopathic hemolytic anemia. Small vessels being affected can include organs like DIC. That is what I've already made a mention of. So DIC. Another example can be HUS. Another example can be TTP. So all these conditions, the first three conditions are example of microangiopathic hemolytic anemia. Microangiopathic hemolytic anemia. See the shape of the RBCs. Shape of the RBCs. Fragmented RBCs. Fragmented RBCs. Right? These are what are being called as schistocytes. That was a 2022's question also, schistocytes. But please remember the fact that whenever we're going to be talking about something like this one, cardiac valve replacement surgery, or a patient having a presence of a giant hemangioma. Giant hemangioma. So you get a hint. Whenever you're talking about a giant hemangioma, giant matlab bada. So it is going to be involving bigger vessels, macroangiopathic hemolytic anemia. And I hope most of you can correlate with the fact, जब भी दिल की बातें करेंगे तो दिल की बात तो बड़ी बात होती है ना यार. दिल की बात मतलब कार्डियक वाल्व रिप्लेसमेंट, बड़ी बात, बड़ी मैक्रोएंजियोपैथी. So DIC, HUS, TTP is going to be microangiopathic hemolytic anemia. Small vessels are affected, whereas cardiac valve replacement surgery and giant hemangiomas is going to result in macroangiopathic hemolytic anemia. Now, why is it of a practical importance? Practical importance is when you're talking about a patient who's going to be having I would say a bad kind of a valve, a valve which requires a surgery, replacement. You are having two types of valves which are always given or available as an option. One which is given the name of a metallic valve, and the second which is going to be given the name of a bioprosthetic valve. Which of them is going to be causing or likely to cause more damage to the RBCs? Metallic valve, bioprosthetic valve. Metallic valve और bioprosthetic valve. दोनों प्रोस्थेटिक हैं यार. प्रोस्थेटिक मतलब आर्टिफिशियल, आर्टिफिशियल दोनों हैं. एक बायोप्रोस्थेटिक है मतलब कि सॉफ्ट मटेरियल से बना हुआ है, और एक मेटालिक है. सो एम फॉर मेटालिक, एम फॉर कॉजिंग मैक्रोएंजियोपैथिक हेमोलिटिक एनीमिया. मेटालिक वैल्व के साथ में प्रॉब्लम आती है. ये एक तो मेटालिक वैल्व होगा तो कार्डिक ऑस्कल्टेशन पे आपको पता चलेगा, खट 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 खट, राइट, ऑस्कल्टेशन. द सेकंड इज इट इज मोर लाइकली टू कॉज द डैमेज टू द आरबीसीज. स्टील वैल्व है ना, सो मेटल वैल्व है, सो आरबीसीज आर मोर लाइकली टू गेट डैमेज्ड. Bioprosthetic valves are going to be having an advantage. Bioprosthetic valves do not cause as much damage to the RBCs. They are soft. They are soft. Right? That is what you need to remember. Metallic valves are having longer life. मेटालिक वाल्व्स की एडवांटेज होती है लॉन्गर लाइफ होती है. So if you have a younger patient who requires a cardiac valve surgery, younger patient requiring cardiac valve surgery, we always prefer metallic valve. Bioprosthetic valve is going to be typically taken from animals. So it is taken from a pig or it is taken from a cow. Pig or cow. What type of graft will that be? Xenograft. Advantage is it is going to be soft. So it is not going to cause hemolytic anemia. But the problem is short half-life, around 10 years. So let us not talk about the cardiac surgery component over here, but we need to be familiar with the concept of microangiopathic hemolytic anemia. So the word is very important. That is what they ask you in the exam as well. Schistocytes. Schistocytes. Schistocytes, which are also being given associated with the term helmet cells. Right? This is what we need to know. Talking about the next one. These are the example of the cells which you are easily able to identify now. On your right side is an example of cell which is having a projection which is equally spaced. Equally spaced. Something which will always and always remind me of my childhood when my nursery teacher used to ask me to draw sun. Echinocyte. Echinocyte. Equally spaced. Also given the second name of Burr cell. Burr cell. Barabar. Equally placed. Right? And whenever we're going to be talking about cells which are going to be having projections which are asymmetrical, either hai, either. So I'm just going to be talking about a cell which is going to be having this, then maybe either, then maybe either. Asymmetrical. Then that is what is going to be given the name of an acanthocyte. Acanthocyte. Acanthocyte is going to be having asymmetrical projections. And if you have watched the videos that we have talked about in the main video discussion for the PYQs, you would remember the fact acanthocyte is going to be seen in patients who are going to be having liver disease and patients who are going to be having A beta lipoproteinemia. What is the commonest cause of liver disease? Alcohol. Acanthocyte, A for alcohol, A for A beta lipoproteinemia. That's how I remember it. Right? You always are going to be talking about them in a spur. Spur of a moment means short notice. So alcohol taken in a spur is responsible for causing liver disease. Liver disease is responsible for causing acanthocyte. That is what is given the name of a spur cell. Right? Spur है यहाँ पे नाम. मेरा नाम मत लिखना यहाँ पे. Spur cell नहीं है ये. Acanthocyte. Right? Echinocyte. Echinocyte. Equally spaced projections. Equally spaced projections. Burr cells. Burr cells. Burr cells associated with the fact patients are going to be having either uremia or the other way of writing uremia is chronic kidney disease. Chronic kidney disease. So when you write Burr cells, remember barabar placed हैं. U for remember uremia, R for remember renal dysfunction. And you can remember an autosomal recessive condition that is given the name of pyruvate kinase. Pyruvate kinase. Pyruvate kinase deficiency. Pyruvate kinase deficiency. What was the keyword regarding pyruvate kinase deficiency that I shared with you? Hemolytic anemia in newborn baby. Hemolytic anemia in newborn baby plus Burr cells. So hemolytic anemia in a newborn baby can also be seen in case of hereditary spherocytosis. But वहां पे cells कैसे? वहां पे cells कैसे होंगे? Spherical cells. Read the question carefully. Hemolytic anemia newborn baby plus Burr cells is pyruvate kinase deficiency. Hemolytic anemia newborn with presence of spherical RBCs is going to be a feature of hereditary spherocytosis. R मतलब renal dysfunction ना. Renal dysfunction में यूरीमिया हो जाएगा ना. बार बार आपको याद दिला रहा हूं मैं ये. बार बार आपको याद दिला रहा हूं ये बात. Equally placed यूरीमिया renal dysfunction. ठीक है, ये चीज आपको याद रखनी है. So that is what is going to be taking care of the question 2023-2024. This is an example of a cell which should not be bringing any kind of a tears to your eyes. Tear shaped cells, tear drop cells, tear drop RBCs, and teardrop RBCs are going to be given the name of dacryocytes. Dacryocytes. Work so hard that on the day of the result, you have tears of happiness coming from the eyes of your parents. Deck cryocytes. So you're going to be having the cells which are going to be having teardrop appearance. Teardrop appearance, teardrop cells or decryocytes. Where would you find them? You would find them in case of situation where the patient is going to be having fibrosis in the bone marrow. Fibrosis in the bone marrow is given the name of myelofibrosis. You can also have it in a patient having iron deficiency anemia, and you can also have it in a patient suffering from myelodysplastic syndrome. Of course, you have it in your notes that it can also be seen in a patient who's going to be suffering from the presence of thalassemia as well. Yeah, so now you understand and relate it well. So patient having dry tap plus dacryocytes, what is the diagnosis? Dry tap plus dacryocytes is seen in myelofibrosis. Myelofibrosis. हाँ हेरी सेल में मिल सकता है यार. माइलोफाइब्रोसिस बेटर वर्ड है. एबनॉर्मल शेप. बहुत सारे सेल्स का ओवरलैप हो जाता है. पैराशूट सेल्स, हेलमेट सेल्स, स्किस्टोसाइट्स ऐसा बोल देते हैं हम. पैराशूट सेल्स, स्किस्टोसाइट्स, हेलमेट सेल्स ऐसा बोल देते हैं किताब में रौनक. सो दिस इज व्हाट वी नीड टू हैव एन आइडिया. Right? This is what you need to keep in mind. So that takes care of our discussion of RBCs. Now talking about something like WBCs. Very first thing that they ask you in the exam pertaining to WBCs. माइलोडिस्प्लास्टिक में तो बता ही दिया ना. माइलोडिस्प्लास्टिक सिंड्रोम में है तो सही. माइलोडिस्प्लास्टिक सिंड्रोम में है तो सही. अरे भाई लिखा तो है. Then we're talking about white blood cells. Of course, white blood cells are going to be having different kind of appearance, and the question has been asked in the exam. We predicted this kind of a question. It was asked exactly in the same way. Instead of giving the names of these cells, they will be replacing it with the numerical number as 1, 2, 3, 4, 5, or they will be replacing it with the word alphabet as A, B, C, D. And then they will ask you to pick up which is the cell that they are talking about. So we understand the fact that lymphocytes are going to be increasing at the time of viral infections. Viral infections. Monocytes, macrophages increase at the time of chronic infections. Eosinophils increase at the time of allergic infections. Neutrophils are going to be increasing at the time of acute inflammation as well as bacterial infection. Acute inflammation as well as bacterial infection. And basophils can again be increased at the time of allergies. Basophils can again be increased at the time of allergies. Viral, monocyte chronic, eosinophils allergy, basophils allergy, neutrophils bacterial infection and acute inflammation. On top of it, combination of eosinophilia and basophilia in the peripheral smear. Always think in terms of CML. Always think in terms of CML. eosinophil के अंदर जो ग्रैन्यूल्स होंगे रेड कलर के ग्रैन्यूल्स होंगे यार. eosino रेडिश, eosinophilic appearance, रेडिश ग्रैन्यूल्स. बाइस्पेक्टिकल्ड अपीयरेंस होती है. बाइस्पेक्टिकल्ड ऐसे चश्मे जैसी अपीयरेंस. न्यूट्रोफिल न्यूट्रल होगा, रेड कलर के ग्रैन्यूल्स नहीं होंगे. 3 से 4 न्यूक्लियर लोब्स होंगे. आई थिंक इन दोनों में डिफरेंशिएट करना आसान है. एक तो स्पेक्टिकल जैसा है, अगर रेडिश है तो eosinophil, अगर ब्लू कलर का है तो बेसोफिल. And the other one is going to be having the presence of 3 to 4 nuclear lobes. That is what is going to be given the name of a neutrophil. Right? So not very difficult for any of you to pick up in the exam. It's likely to be an easy question. Right? The next thing that we need to have an idea is the concept of leukemias. The concept of leukemias. Whenever we are talking about leukemias, the fundamental problem that we have in the patient is that we are having the presence of the bone marrow, in which we are having the presence of precursor cells, which are going to be proliferating at a very fast rate. So problem number 1, the red color cells are abnormal cells, they are cancer cells, and these cancer cells are going to replace the normal cells. So when they replace normal cells, there will be decrease in RBCs, decrease in WBCs, decrease in platelets. Decrease in RBCs, decrease in WBCs, decrease in platelets. That's trouble number 1. Trouble number 2, these cancerous cells are going to come out from the bone marrow. and they are causing involvement of liver. They are going to be causing involvement of spleen, and they are going to be causing enlargement of lymph nodes in the body. So there is going to be hepatomegaly, splenomegaly, and lymphadenopathy. Hepatomegaly, splenomegaly, and lymphadenopathy. In some of the patients are having features of red RBCs, anemia हो जाएगा, fatigue, pallor. WBCs are less, so patients are going to be having high chance of fever, infections. Platelets are less, so patients are going to be having increased chances of bleeding. So hepatomegaly, splenomegaly, lymphadenopathy, and patient is having a pallor, patient is having the presence of thrombocytopenia, there is a rash because of bleeding, and the patient is going to be having high risk of infections. So these are the important manifestations of leukemias. Some of the patients in case of leukemias can be having bony tenderness. Particularly in case of children, you will have a history of development of sternal tenderness. History of development of sternal tenderness. You press the sternum of the baby is going to wince in pain. The baby starts crying. Now, please remember, if the patient is going to be having a short history, if there is a short history given in the patient, you call it by the name of acute leukemia. Acute leukemia, typically the patient is having a history of few days. So the patient will come and tell in your clinic that, doc, I was absolutely fine 10 days back. I was absolutely fine last week. I was absolutely fine 5 days ago. Right? So he's coming to you on a Friday and he says he was absolutely fine on Sunday, absolutely fine on Monday. But suddenly he notices that he is suddenly feeling very weak. He has fever. He notices a rash. And he has a heaviness in the abdomen. So when you palpate, you have a hepatomegaly, you have a splenomegaly, you can even have development of lymphadenopathy. So when there is a short history, that's called as an acute leukemia. But when the patient is going to be having a long history, so long, sometimes people or patients also don't remember it. Many years, they have this very kind low grade fever kind of a thing, which they may ignore. Or the patient doesn't have an idea. Chronic leukemias can be an example of an incidental finding. This can be an example of an incidental finding. So many years are going to pass by before you make a diagnosis of chronic leukemias. Now, practically speaking, two that you are having in the bone marrow. One which is going to be given the name of a lymphoblast, from which lymphocytes are going to be coming. And the second one, which is given the name of myeloblast, from which RBCs, platelets, and the other white blood cells are going to be coming. Right? How do you differentiate between them? The differentiation is done on the basis of appearance as well as stains. In case of lymphoblast and in case of myeloblast, if you just see and make a comparison. L for lymphoblast, it is having the presence of a little cytoplasm. Little cytoplasm. See with the arrow. Cytoplasm is very less. Right? And do you find any granule in the cytoplasm? The answer is no. So in case of lymphoblast, what we remember over here is a classical finding, agranular cytoplasm. Agranular cytoplasm. No nucleoli. Agranular cytoplasm, and you are going to be having the presence of no nuclei, which can be seen over here. It is having a condensed nucleus. See the myeloblast. See for comparison. If you see the cytoplasm over here, see the cytoplasm, see the cytoplasm, see the cytoplasm. In comparison to a lymphoblast, the cytoplasm is going to be more. The cytoplasm is going to be more. So myeloblasts are going to be having granular cytoplasm. Myeloblasts are going to be having granular cytoplasm. And a lot of you have an idea that this granular cytoplasm, as you can see over here, the dot-like structure that you are having over here. Sometimes there is going to be presence of rod-like structures as well. These rod-like structures are going to be given a special name. They are called by the name of Eor rods. Eor rods. ठीक है। राशिका नाराज हो गई। राशिका, पैनसाइटोपिनिया जरूरी नहीं है कि आपको हर क्रोनिक ल्यूकेमिया में मिले, बट आपको प्रीडोमिनेटली वहां पे देखने को मिलेगा द इंपॉर्टेंट फीचर ऑफ वन पर्टिकुलर सेल बीइंग इंक्रीजिंग। ठीक है। When you are having a group of your rods, these cells are going to be given the name of faggot cells. Too many of them being present together, that is given the name of faggot cells. So there are two types of cells which are going to be present in the bone marrow. That is what we just need to have an idea. Either it is a lymphoblast or it is going to be a myeloblast. Lymphoblast or myeloblast. So you look at two important features when you talk about making a diagnosis of a patient. First, whether the patient is having a short history or whether he is having a long history. Short history means acute presentation. Long history means chronic presentation. Right? Which is the cell which is going to be involved? Either it is going to be an example of a myeloid cell or it is an example of a lymphoid cell. So when we are talking about an example of an acute presentation and you have a myeloid cell, the cancer is called as AML. Acute leukemia, the cell is myeloblast, acute myeloid leukemia. If it is a short presentation and the cell is a lymphoblast, we call it by the name of ALL. Acute leukemia, and the L is a cell that is going to be lymphoblast. We'll talk about stains. Don't worry. Don't worry. Gurusharan Pratiksha. थोड़ी प्रतीक्षा कर लो. गुरु की शरण में आ जाओ. AML, ALL, acute presentation, the cell is different. Myeloblast and lymphoblast. When we are talking about long presentations, chronic myeloid leukemia, chronic lymphocytic leukemia. So even when you look at the name, you will have some kind of an idea about presentation of a patient one and the cell that is expected to be seen. Right? Now, talking about the morphological appearance. ये appearance आपको समझ में आ गई. A granular cytoplasm and condensed nucleus is a finding of lymphoblast. Granular cytoplasm and presence of nucleoli is going to be a feature of something like a myeloblast. What are the stains which are going to be used for them? Stains which are used for lymphoblast include TDT and PAS. TDT and PAS. Stains which are useful for identification of myeloblast. Myeloperoxidase, Sudan black B, non-specific esterase. Non-specific esterase. And MPO, myeloperoxidase, Sudan black B, non-specific esterase. But nowadays, we are not relying on morphology completely because we are having better ways to identification of these cells. And the better way of identification of these cells happens to be something like CD markers. How do you detect CD markers? Flow cytometry. How do you detect CD markers? Flow cytometry. इसका क्या निमोनिक है यार? M for myeloblast, M for myeloperoxidase. Myeloblast, myeloperoxidase. Lymphoblast, TDT, and pass. You have to pass your exam. So you just remember about this fact. ठीक है? So what is going to be the presentation of the patient? This is the presentation. So whenever we are going to be talking about a patient who's going to be having acute leukemia, I hope this is easy now. Acute leukemia. You can have two types of acute leukemias, AML and ALL. What is going to be the problem in the patient? There is going to be interference with the different types of cells, RBCs, WBCs, and platelets. The difference is with respect to the age group. Majority of the patient having ALL are going to be children. Majority of the patient who are going to be having AML are going to be old age people. Right? So a child who's going to be having the presentation in the form of a short history, having the presence of features of fever, presence of pallor and fatigue, presence of skin rash or thrombocytopenia is going to be at high risk or he's going to be likely to be suffering from ALL, short history. Older person having a similar kind of a feature, shorter history is going to be suffering from something like AML. I hope that much should be clear to most of you. ये basic fact है. Right? If this is what is clear to you, then we can always talk about the presentation of a patient and the important findings. So when I'm talking about lymphoblasts, I repeat for the third time, agranular cytoplasm, condensed nucleus. When they are going to be having a short history, acute leukemia. And the cell being present over here is a lymphoblast. So I will call it by the name of an acute lymphoblastic leukemia. Now, whenever we are making a mention of acute lymphoblastic leukemia, it is the most common blood cancer that is seen in case of children. Most common blood cancer that is going to be seen in case of children. Right? Doc, as per the WHO, we don't have a blast criteria cutoff over here. But yes, for the sake of simplicity, we say that it is likely to be more than 20%. It is likely to be more than 20%. Now, what we need to remember over here is going to be history से आपको hint मिल गया छोटा बच्चा child having shorter history, having the presence of hepatosplenomegaly, lymphadenopathy, pancytopenia, and having the presence of a sternal tenderness. Right? Now, how many types of lymphocytes are you aware of? This is a concept. We can be having the presence of pre-BALL and pre-TALL. This concept is important. This concept is important, right? Because when we are talking about the lymphocytes दो टाइप के होते हैं, B lymphocytes and T lymphocytes majorly. So when we are talking about a lymphoblast means precursor cell, immature cell. So if I'm aware that lymphocytes are of two types, B cell and T cell, I can say the cancer can also be of two types, pre-BALL and pre-TALL. Pre-BALL and pre-TALL. What is the difference? The difference is very simple. Pre-BALL is what is going to cause involvement of marrow. Pre-TALL is what is going to be causing involvement of thymus. Why is this important? Pre-BALL is going to be more common. Pre-TALL is going to be less common. What's the practical significance? If your patient is having a cancer, unfortunately, he is not interested in the classification, just like you are not interested in the classification as of now. So what are they interested in? They are interested in knowing about prognosis. If a patient is going to be having pre-BALL, the prognosis happens to be better. And if a patient is going to be having pre-TALL, the prognosis happens to be poorer. So we remember the fact that pre-BALL is going to be having B for better prognosis. Or we remember B for badhiya, better prognosis. The T cell cancer is going to be more aggressive. Because it is more aggressive, so it is going to be having a poorer prognosis. Poorer prognosis. So whenever we make a diagnosis of ALL, we have a short history, we have a child. When we are talking about a child and the child is going to be having the presence of a pre-BALL, we counsel the patient that your prognosis happens to be better because you are having a higher chance of responding to anti-cancer drugs. But when my patient is going to be having pre-TALL, I will say that your prognosis happens to be guarded. It is not very good because it is likely to be more aggressive. Right? What is going to be the clinical presentation of a patient having pre-BALL? Patient is going to be having extensive involvement of bone marrow, so he is going to be having features of pancytopenia. Patient who's going to be having pre-TLL is going to be having thymus involvement. And thymus involvement in your exam is going to be given in the form of chest X-ray finding of a patient that shows mediastinal widening. Chest X-ray of the patient shows you presence of mediastinal widening. So any question in the exam which gives you a hint that the patient is going to be having chest X-ray finding and there is a mediastinal widening, that shows the patient is going to be having a retrosternal mass. Thymus is retrosternal. So if you are having the presence of a retrosternal mass, that itself is going to be an indicator for the fact that the patient is going to be having the presence of a cancer. And this kind of a cancer that you need to remember is going to be a pre-TAL. I hope the concept is clear. How would you identify them? What is a marker that is useful for identification of a B cell? CD1920. And we remember a marker called as CD10. What is a marker that is going to be useful for making a diagnosis of a or identification of a T cell? CD1 1357. 1357. So you have a patient who's coming to the clinic with symptoms, short history, you suspect a cancer. You do the bone marrow examination, look at the cell, look at the morphology. The cell is having a granular cytoplasm condensed nucleus. You stain it with the help of TDT and pass. You come to the diagnosis of lymphoblasts. Then you do a test which is given the name of flow cytometry. Flow cytometry will tell you whether your patient is having a pre-TLL or whether he's having a pre-BLL. Depending upon what is going to be seen in the patient, you're going to be making a diagnosis of the patient as whether he's going to be having a better prognosis or whether he's going to be having a poorer prognosis. That is what you need to remember over here. Okay. So just make this correction as 1, 2. 1, 2 कर ले भाई से. How do we search in the cell for CD markers? CD markers is done with the help of flow cytometry. Flow cytometry. Why are we not using CD4 and CD8? Because they are the markers for differentiated cells. They are the markers for differentiated helper T cell and a marker for differentiated cytotoxic T cell. So that's why we are using markers like these. Now, what is going to be asked to you as a question in the exam? पैन टी सेल मार्कर है ना, तो उससे हमें डिफरेंशिएशन नहीं मिलेगा. बेसिक आपको मार्कर का कंसेप्ट पता होना चाहिए कि these markers are useful for identification of a B cell precursor. This is useful for identification of a T cell precursor. Now, what is going to be important for you to remember over here is going to be, this is what they'll have to ask you as a question in the exam. High yield stuff for the exam. Prognostic factors of ALL. Short history, see the morphology, do the staining, look at the markers. What you need to remember over here is, if I can just make a correction over here, this is 1 year. So when the age of the patient, all these factors means good prognosis. All these factors means bad prognosis. हम ज्यादा कॉमनली मार्कर यूज करते हैं यार CD10. CD10 यूज करते हैं बी के लिए, और हम ज्यादा कॉमनली मार्कर्स यूज करते हैं 1357 टू बी ऑनेस्ट फॉर टी सेल. बट अगर नोट्स के अंदर वैसा दिया हुआ है, सो आई जस्ट हैव अ क्रॉस चेक. बट 157 आर बट डेफिनेटली यूज ओवर हियर. 4 and 8 are not being used because they are the markers for differentiated cells. When we're talking about the age of a patient, if a patient is having age between 1 to 10 years, that means good prognosis. The reason is simple. Whenever we are talking about age of a patient less than 1 year, he will not be able to tolerate chemotherapy. बहुत ही छोटा patient हो जाएगा, infant हो जाएगा. When a patient is going to be having age more than 10 years, then that patient is going to be more likely to be a teenager. And whenever we are talking about teenager, remember T for teenager, teenagers are more likely to have T cell cancer. So prognosis happens to be bad. Female sex means good prognosis. Ladies are lucky. चाहे वो माँ के रूप में हो, चाहे वो बहन के रूप में हो, चाहे वो बेटी के रूप में हो, चाहे वो अच्छी दोस्त के रूप में हो. Ladies are lucky. Lady luck, females. L1 lucky. When the blast count is going to be less than 1 lakh. L1 less than 1 lakh. हाँ भाई, आपकी वाइफ के रूप में भी होगा, चिंता मत करो. बी सेल, बी से बढ़िया प्रोग्नोसिस, बेटर. And whenever it is going to be having, now this is what is required for the higher up exams, hyperdiploidy. When the tumor cells are going to be showing you, L1 is a morphology of the cell. L1, L2, L3 is a morphology of the cell. Right? So hyperdiploidy, or we are going to be having the presence of trisomies. Translocation 1221 or trisomies 4, 7, and 10. This is what is very, very important. This is most often forgotten part in the discussion. Right? So hyperdiploidy, more than 50 chromosomes, and translocation 1221. Right? Whenever we're going to be talking about trisomies, lucky 7, tri means 3. 7 plus 3 is 10, 7 minus 3 is 4. याद रहेगा. लकी 7 का प्रोग्नोसिस बेटर है. ट्राइसोमी की बात हो रही है. ट्राई मतलब 3. 7 plus 3 10, 7 minus 3 4. Trisomies 4, 7, 10 is going to be good prognosis. हाँ, थाला मैं नहीं झुकेगा साला. ठीक है, एग्जाम में याद रख लेना. When we are talking about poor prognosis, Any patient who's going to be having age less than 1 year and age more than 10 years is going to be having poorer prognosis. Less than 1 cannot tolerate chemotherapy well. More than 10 is going to be cancer is more aggressive. Males, obviously, more aggressive. L2, L3. Blast count, L2, L3. Blast count is higher. So that means tumor burden is higher. Prognosis is bad. Pre-T, pre-T, T for thymus. In the males, you can also be having T for testicular involvement more commonly. Thymus is involved, it can result in mediastinal mass. It can result in mediastinal mass. In males, if there is involvement of the testicular tissue, poorer prognosis. Right? And if there is going to be a brain involvement, obviously that is going to be a bad news for the patient. Again, talking about an area which is often forgotten by the people. If there is going to be pseudodiploidy, if there is going to be a translocation 922, translocation 922, or there is a translocation 814, or there is a translocation 411, they means poor prognosis. Most of these translocations are going to be associated with TLC काउंट 20,000 भाई ब्लास्ट काउंट की बात हो रही है ब्लास्ट काउंट TLC काउंट और ब्लास्ट काउंट अलग अलग चीजें होती हैं TLC count means total leukocyte count, mature cells. Blast count means we are talking about immature cells. Right? So that is what you need to remember. हाँ जी अभी डाउन्स की बात नहीं हो रही यहाँ पे यार डाउन्स का प्रोग्नोसिस ऑब्वियसली बेटर बैड होता है इसमें सो माय हम्बल सजेशन इज whichever you find more comfortable to remember please remember that one. I always prefer to go with this one. Good prognosis. अच्छी चीजें याद रखो. Easy for you to remember. Age is easily remembered 1 to 10. Lucky ladies L1 1 lakh से count कम B for better mediastinal mass absent presence of hyperdiploidy, more the number of chromosomes, more is the sensitivity of the tumor. And when we are going to be talking about something like trisomies, trisomy 1221. पहले 12 लिखा उसको उल्टा कर दिया 21. So the prognosis happens to be good. And trisomies 4, 7 and 10. Trisomies 4, 7 and 10. Might not be given in the workbook directly, the prognostic factors. It has been written in one line in the workbook. It has been written in one line in the workbook. That is what you need to remember. In fact, workbook समझ याद आया. You have to make that correction. You have to make that correction. The workbook is 4, 7 and 10. 4, 10, 17 नहीं है वो 7 है 7. 4, 10, 7. QRR के अंदर 4, 7, 10. That's what you need to remember. Right? So this is about ALM. Then talking about the next one, in which you are going to be having the presence of cells like this. Of course, you will be able to revise with me. More cytoplasm, granular cytoplasm. वर्कबुक में ठीक लिखा हुआ है अच्छी बात है किसी एक जगह पे गलत लिखा हुआ था यार सो आई हैव जस्ट नोटेड इट डाउन एंड ड्यूरिंग आवर डिस्कशंस इट कीप्स ऑन क्रॉपिंग कि सर आपने 4 7 10 बताया था किताब के अंदर वहां लिखा हुआ है नोट्स के अंदर 4 10 17 तो करेक्ट कर लेना सो दिस इज गोइंग टू बी एसोसिएटेड विद द प्रेजेंस ऑफ ग्रैनुलर साइटोप्लाज्म यू कैन ऑलवेज सी द प्रेजेंस ऑफ समथिंग लाइक एयर रॉड्स ओवर हियर air rods is going to be made up of eosinophilic granules. When you have a cell which is going to be having too many air rods, that is going to be given the name of faggot cells. Or you associated with the term 5 bodies. 5 bodies. Right? That is what you need to remember. Less than 1 हो जाएगा भाई, less than 1 और 10 से ज़्यादा. Less than 1, 10 से ज़्यादा, bad prognosis. Between 1 to 10. इसको correct कर लो please. So this is what you need to. Investigation of choice is going to be bone marrow biopsy followed by flow cytometry. Flow cytometry is a confirmatory investigation. Flow cytometry is the confirmatory investigation. Then we're talking about a cancer that is going to be given the name of AML. Short history, the cancer is going to be myeloid. Now, whenever we're going to be talking about the myeloid cancer, it is a cancer that is going to be seen in case of elderly people. And we have a WHO classification of AML. This is what I want you to remember, and therefore I have not made a mention of this one in the notes as well. So I just want you to be familiar with this one. First category of AML is AML, which is having specific translocations. or specific genetic defects. Second type of AML is AML associated with maturation problem, myelodysplasia. Third type of AML is AML, which is going to be associated with therapy. Fourth type of AML is AML, which is not fitting in any of these categories, not otherwise specified. So these are four types of categories of AML. AML with specific genetic defects or translocations, AML with or without the presence of myelodysplastic syndrome, but myelodysplasia is present, AML which is therapy related, and AML which is not otherwise specified. Few examples that would be able to help you in the exams: AML with specific translocations, AML with a translocation 821, AML with a translocation 1517, AML with a translocation V11, V11. And you can be having a situation in which the patients could be having AML, which is going to be therapy related. Therapy related का मतलब है patient is having a history of radiotherapy or patient is having a previous history of taking anti-cancer drugs. Why is this important? क्यों याद रखें हम इसके बारे में? ये चार ऑप्शंस बनती है एग्जाम के अंदर. Any patient who is going to be having AML with specific genetic defects is going to be having the best prognosis. इसका प्रोग्नोसिस बेस्ट होता है. इसका प्रोग्नोसिस बेस्ट होता है. Right? Any patient who is going to be having the AML which is going to be developing after therapy is going to be having the worst prognosis. Worst prognosis. So at least for your exam, you just need to have an idea that patients are going to be having either the best prognosis or the worst prognosis. In चार options में आपको पता होने चाहिए. You should be having an idea out of the given four options. The first one is having the best prognosis because there is a specific genetic defect, and the one which is developing after the therapy is going to be having the worst prognosis. No, we use WHO classification doc, not the FAB one. FAB is dependent upon morphology. FAB हम MCQ के लिए यूज करते हैं थोड़ी बहुत इंफॉर्मेशन का, अभी बताऊंगा थोड़ी देर में. We are not going to be having dinner now, not so early, right? And then we are going to be having a discussion about something which is going to be associated with. अगर आप चाहते हो सुनना तो 16 याद रख लो यार, ये लो. इन्वर्जन 16 भी बोलते हैं इसको, right? So when we are talking about the patients who are going to be having the presence of AML, this is dependent upon the depiction of percentage of the blasts. In AML, you have to show how many blasts, more than 20% of blasts. To make a diagnosis of AML, you have to show more than 20% of blasts. Right? But if you have a patient, and listen to my words very carefully, if you have a patient who's going to be having specific genetic defects, if you have a patient who's going to be having 20% of blasts in the bone marrow biopsy, very right, 20% of the blasts in the bone marrow examination, then that is what is going to be required for making diagnosis of AML, not for ALL. ALL का WHO नहीं बोलती, हम बोलते हैं वो for the sake of simplicity. Number of blast is not defined by WHO for ALL, वो AML में defined है. हम simplicity के बोलते हैं कि हाँ 20 से ज्यादा है, right? But if you read the manuals, you will have it only for AML. Now, if you have a patient who's going to be having AML which is not otherwise specified, you have to show 20% से ज्यादा blasts. If you have to talk about AML which is therapy related, again you have to show more than 20% of blasts. If you have to show AML with dysplasia, it is going to be having more than 20% of blasts. But on the cytogenetic analysis, and listen to my words carefully, on the cytogenetic analysis, if you are able to show these specific translocations, then there is no cutoff value of blasts. There is no cutoff value of the blast. इसका मतलब क्या हुआ? इसका मतलब हुआ इफ यू हैव अ पेशेंट हैविंग अ प्रेजेंटेशन इन द फॉर्म ऑफ एएमएल, शॉर्ट हिस्ट्री, पैनसाइटोपिनिया, हिपैटोस्प्लेनोमेगाली, lymphadenopathy, morphology shows you presence of a cell which was having aor rods, and by cytogenetic analysis, if you show the cell to be having a translocation 1517, even if one cell is seen, one cell, you make a diagnosis of AML. There is no cutoff value of the blast in the first category, category 1. There is no cutoff value of the blast in the first category in which you can show by cytogenetic analysis specific genetic defect or specific genetic translocation. No cutoff value is applicable over here. So this can be giving rise in the order of, I would say, the toughness of the questions for the exam. So 4 options, सबसे अच्छा सबसे खराब prognosis आपको idea होना चाहिए. Then for the one which is going to be having the most appropriate prognosis, no cutoff value of blast is going to be applicable. Now, if you are asked a question exam from these four, if you are asked a question exam from these four, the ones which I'm highlighting now, 1616, 821, 1517, all of them are going to be having good prognosis. But if I'm talking about translocation variable 11, this one is having poorer prognosis. So overall speaking, mark my words carefully, overall speaking, AML with specific genetic defects has good prognosis with the exception of AML which is having translocation V11. What is V? Variable. 16 वाला 16 के साथ जा रहा है, 8 वाला 21 के साथ जा रहा है, 15 वाला 17 के साथ जा रहा है. V मतलब वेरिएबल, ये किसी के साथ भी चला जाता है. जो किसी के साथ भी चला जाता है वो कभी भी अच्छा नहीं होता, प्रोग्नोसिस खराब होगा. ऐसे याद रखना है आपने. जो किसी का ना, जो सबका हुआ वो किसी का नहीं हुआ. राइट, सो प्रोग्नोसिस इज बैड. ठीक है, दैट इज व्हाट यू नीड टू रिमेंबर सो फार एज अ WHO क्लासिफिकेशन इज कंसर्न. अभी बात करते हैं फैब क्लासिफिकेशन, जिसके लिए काफी सारे लोग चिंतित थे. फैब क्लासिफिकेशन के हिसाब से दिस इज व्हाट वी नीड टू रिमेंबर. फैब क्लासिफिकेशन, इसमें कुछ कुछ कैंसर्स के बारे में ज्यादा कॉमनली क्वेश्चन आते हैं, इसलिए वी आर टॉकिंग अबाउट दिस. सो आई विल जस्ट हेल्प यू कोरिलेट बोथ ऑफ देम. When we are talking about Fab classification, how many types of AML are there from M0 to M7? टोटल कितने हो गए भाई? टोटल काउंटिंग करनी है, 8 हो गए. 8 हिमांशु जी, 7 नहीं हुए, 8 हुए. 1 से लेकर 7 तो है ही, लेकिन 0 भी तो है. तो ये गलती आपने अवॉइड करनी है. सेकेंड फैक्ट आपने याद रखना है, दिस इज अ AML which is given the name of AML M2. AML M2 was associated with the translocation. This translocation is given the name of translocation 821. This is an example of a AML which is going to be important for multiple reasons. Reason number 1, it is very common. Reason number 2, it is going to be causing involvement of the eyes. When it causes involvement of the eyes, it is going to be moving outside the bone marrow. It is outside the bone marrow, tumor cells are going to accumulate. So it is extramedullary cancer, extramedullary AML. And this extramedullary collection of tumor cells is given the name of chloroma. So how is a chloroma going to present? Chloroma is going to be presenting in the form of proptosis. It is going to be presenting in the form of proptosis. So it is common. It is associated with the extramedullary mass and it is going to be associated with proptosis. So that becomes a pathology ophthalmology question. When we are talking about AML M3, AML M3 is now called as acute promyelocytic leukemia. This is associated with the translocation 1517. These patients are at high risk of suffering from DIC. So this is what is going to be responsible for causing death of the patient. Why are we having 1517? You got a question in the exam 2022, 2023. आपको एग्जाम में क्वेश्चन आया था that these were the patients who are going to be having the formation of a gene, PML RARA fusion gene. PML RARA fusion gene. What is going to be the presentation of a patient having DIC? जो क्वेश्चन आया था 2024 के अंदर. These patients are going to be having decrease in the platelet count. They will be having increase in PT. They will be having increase in APTT. Decrease in platelet count, increase in PT, increase in APTT. So 5 questions from acute promyelocytic leukemia. I will repeat my questions. Question number 1, What is the translocation? 15, 17. Question number 2. What is the problem in the patient? Formation of PML-RARA fusion gene. Question number 3. What is the cause of death in the patient? High risk of development of DIC. Question number 4. What is the presentation of DIC? Increase in PT, increase in APTT, decreased platelet count. Question number 5. Can you treat this cancer? The answer is yes. We have read path, we have read pharma. So we will give to this patient a drug that is given the name of atratherapy. Question number 6. If atratherapy is going to fail, what is the next drug which can be given? Arsenic trioxide. Question number 7. What is the mechanism of action of atra and arsenic trioxide? This is what we discussed yesterday. So mechanism of action of atra and arsenic trioxide is, they are examples of differentiation therapy. Differentiation therapy. I hope this is clear. So this is about acute promyelocytic leukemia. Patients are going to be having a presentation in the form of DIC, and the patient's life is going to be in danger if you do not diagnose it well. That is what I discussed with you yesterday as well. फ्राइडे को रिपोर्ट आती है लैब के अंदर, आपको इसको एक्टिवली इन्वेस्टिगेट करना पड़ता है बिकॉज मंडे तक मरीज की सिर्फ डेड बॉडी मिलेगी. And if you are able to diagnose it and you are able to start atra therapy, the patient is going to live. So it is rapid deterioration versus a living patient. You have a choice. Right? Atra therapy is usually treated 90% of the patients, but for remaining patients, you are going to be having arsenic trioxide. Right? Then you're going to be having a question asked in the exam on something which is going to be given the name of M4, M5. M4, M5 is important because they are responsible for causing gum hypertrophy. Gum hypertrophy. So patients are going to be having gingival hyperplasia, gum hypertrophy. Just like you read about gum hypertrophy with an example of an anti-epileptic drug, similar thing. M4, M5 associated with which anti-epileptic drug? ये तो आसान क्वेश्चन है. Phenytoin. Similarly, you're going to be having gum hypertrophy or gingival hyperplasia with which type of AML? M4 or M5 AML. Myelomonocytic या फिर monocytic. Then you are asked a question in the exam on this one, AML M7. This is given the name of acute megakaryocytic leukemia. This is the one which is very commonly seen in a patient suffering from Down syndrome. Seen in a patient suffering from Down syndrome. And why that becomes important? Because these patients are going to be having the development of fibrosis in the bone marrow. So this is going to be associated with development of myelofibrosis. Associated with the development of myelofibrosis. डिफरेंशिएशन सिंड्रोम वर्सेस थेरेपी, क्या कष्ट हो गया भाई प्रतीक, समझ नहीं आया मुझे. डिफरेंशिएशन करते हैं ना इसमें, डिफरेंशिएशन थेरेपी इज एप्लीकेबल फॉर एपीएल. M7 acute megakaryocytic leukemia is more so commonly seen with Down syndrome, that is trisomy 21, and trisomy 21 patients are going to be at high risk of suffering from myelofibrosis. So myelofibrosis means the patients are going to be having the presence of a dry tap over here. This is what you need to remember so far as M7 AML is concerned. Right? So cytogenetic analysis, please remember the fact, cytogenetic analysis is what is going to be useful for making a diagnosis of the patient. ड्राई टैप होगा ना पेशेंट का, तो बोन मैरो बायोप्सी करनी पड़ेगी. M6 का कुछ सेवन खास नहीं है. M6 के अंदर एरिथ्रोइड ल्यूकीमिया होता है, एरिथ्रोसाइट प्रिकर्सर्स होते हैं. ये पीजी एग्जाम का टॉपिक होता है. दिस इज गोइंग टू बी हैविंग द प्रेजेंस ऑफ पैची और डॉट ब्लॉट पीएएस. साइटोजेनेटिक एनालिसिस, साइटोजेनेटिक एनालिसिस आपको देखना पड़ेगा ना, whether the patient is having this defect, whether the patient is having this defect, whether the patient is having some other defect. So that can be done on the basis of cytogenetic analysis. Histopath हम करते हैं, but if you are having the availability, of course you are nowadays going in for the detection of the genetic defect in the cancer. Number of percentage of cells which are going to be undergoing maturation. नहीं, M4 M5 दोनों के अंदर होता है. M5 के अंदर ज्यादा होता है गम हाइपरट्रोफी. फिश नहीं करता इसके अंदर. साइटोजेनेटिक के अंदर फिश भी आता है यार. फिश करते हैं हम जब सिर्फ और सिर्फ आपके पेशेंट्स के अंदर आपको दिखाना होता है ये वाली चीज. When you know about the translocation, specific translocations, then you do fish. Right? That is what you need to remember. डिफरेंशिएशन सिंड्रोम, वो सिंड्रोम और थेरेपी एक ही बात है, एट्रा थेरेपी है, एट्रा थेरेपी। इसी के साथ में लिखा होगा ना, एपीएल के साथ में लिखा होगा, एपीएल के साथ में लिखा होगा ना, सो दैट इज गोइंग टू बी एट्रा थेरेपी, राइट? सो दैट इज व्हाट यू नीड टू रिमेंबर सो फार एज एएमएल इज कंसर्न। लुकीमियास खत्म कर लेते हैं यार, देन वी कैन हैव अ डिनर ब्रेक। बस 10 मिनट का आपका और कॉपरेशन। दिस इज व्हाट इज गोइंग टू बी गिवन द नेम ऑफ क्रॉनिक लिम्फोसाइटिक ल्यूकीमिया। You get a hint, chronic. Leukemia means blood cancer. So it's an example of a B cell cancer. B cell cancer. And this is an example of a cancer which is going to be arising from naive B cell. Naive B cell. Why should we be aware about this? We should be aware about this particular cancer because it is the most common cancer that you are having in case of, most common blood cancer that you are having in case of adults. For a lot of patients, this is going to be an example of an incidental finding. So patients are going to be, individuals are going to be asymptomatic. How will they come to the light? You will make a diagnosis of this patient because this patient comes to your hospital for a routine checkup. जैसे वो दिवाली वाला हैप्पी न्यू ईयर आता है ना, या हैप्पी फादर्स डे, हैप्पी मदर्स डे करते रहते हैं, राइट? सो दिस वन इज गोइंग टू बी एसोसिएटेड विद ल्यूकोसाइटोसिस. And when you do look at the high leukocyte count, you look at the lymphocyte count of this patient, the lymphocyte count of this patient is also going to be higher. ठीक है? So there is going to be lymphocytosis. Now what can also be seen in these patients is the patients could be having a development of sometimes fever, or they could be having the presence of a lymph node enlargement. Fever, or the patients could be having the presence of a lymph node enlargement. Any patient who is going to be having CLL, once you want to investigate this patient, आपने देखा patient का lymphocyte count high है, lymphocyte count is high, and this is going to be associated with कौन सा syndrome रह गया भाई? डिफरेंशिएशन सिंड्रोम कह रहे हो, एट्रा थेरेपी भाई। सीएलएल में एसोसिएटेड सिंड्रोम, अभी पढ़ा तो रहा हूं यार, आने तो दे उसे। एसोसिएटेड सिंड्रोम. So we are going to be talking about TLC count being high, and then you look at the peripheral smear of the patient. Peripheral smear of the patient is going to be showing you cells which are going to be given the name of smudge cells. Smudge cells. You look at this picture, tumor cells are going to be getting burst. When you make the smear, the tumor cells get burst. Look at these. Tumor cells are going to burst. So they are going to get smudged, or they are going to get crushed. That's what is given the name of a smudge cell. So you were asked a question 2022 के अंदर that a patient is an elderly patient. 60-year-old patient comes to you because he's having fever. His peripheral smear shows you the presence of smudge cells. What is the next best investigation? If I have a patient who is falling in and matching this criteria, elderly patient, he is going to be having the presence of fever and lymph node enlargement. He is having the presence of smudge cells. I will think in terms of a cancer like CLL. And how will I confirm this cancer? I will confirm this cancer with the help of an investigation. The investigation of choice for these patients is flow cytometry. Then comes the 2021 INI-CT question. What is the flow cytometry finding? So this is an example of a cancer in which tumor cells show you CD5 and CD23 positivity. CD5 and CD23 positivity. Investigation of choice for CLL is flow cytometry. Flow cytometry finding is CD5 and CD23 positivity. Why is there is going to be CD5 and CD23 positivity? For the simple fact, अगर ये बी सेल कैंसर होता तो CD23 एक्सपेक्टेड था, CD23 एक्सपेक्टेड था, but CD5 is a marker for which cell? T cell. So you are having an abnormal B cell, which is also having the presence of a T cell marker. That is why it is an abnormal cell. That is why it is a cancerous cell. So it is having a marker of B also, T also. So it is not a normal cell. That's why it is a cancerous cell. That's why we say it is an example of a cancerous cell. I hope you are clear with this. Right? If you look at the tumor cells over here, one problem can be that they can get crushed. So that is given the name of smudge cell. The second thing is these are the tumor cells or the lymphocytes. The tumor cells appear very similar to each other. When tumor cells are going to appear very similar to each other, That is going to be making you resemble of your school days. दूर से देखो सबका यूनिफॉर्म एक जैसा था. So that is what is going to be given the name of convent girl appearance. Peripheral smear appearance is what is going to be given the name of convent girl. School girl appearance, convent girl appearance. Convent girl appearance. That is what you need to remember over here. Appearance wise same. Not because of the fact the cell line. Of course, there is going to be lymphocytic involvement only. The next thing that we need to remember over here is this is going to be again for certain hi-fi questions. 13q deletion is seen in the patients. 17p deletion is going to be seen in the patients. This is most common genetic defect. And the second genetic defect is the one which is going to be associated with worst prognosis. 13q deletion. 13q deletion is the most common genetic defect seen in a patient having CLL. जैसे तुम बोल रहे हो कॉन्वेंट बॉय का नहीं बोलते, वो कन्या यार ज्यादा अच्छे तरह से वो तेल वेल लगा के चुटिया बना के जाती थी ना. तुम तो अपने यहाँ पे रुमाल बांध के और कभी शर्ट अंदर है कभी बाहर है. देखा ही होगा तुमने. ठीक है. So this one is going to be associated with 17p deletion. That is going to be associated with a poorer prognosis. You do the analogy na as of now. You do the analogy as of now. Out of 20 people asking for a dinner break, 19 will be boys. जाने दो, खाना खाने दो, ब्रेक दे दो, ब्रेक दे दो, ब्रेक दे दो. हाँ बस यही बचपन से लेकर अभी तक यही चल रहा है. बस दे दो, ब्रेक से लेकर खाने तक दे दो बस. ठीक है चलो जी, ये वाली कहानी ठीक है. CD5 1921 23 23 is a marker of शौमिक शीघ्र हो. अनेक अनेक शुभेच्छा, जल्दी होगा. ठीक है. सो दिस इज व्हाट यू नीड टू रिमेंबर. इमेज तो देख जाओ भाई, बस इमेज देख के चले जाओ, जाओ ऐश करो. CML इसका 90% इंफॉर्मेशन तुमको ऑलरेडी पता है. ट्रांसलोकेशन 922, BCR ABL fusion gene, also given the name of Philadelphia chromosome. So patient is going to be having the presence of massive splenomegaly. Massive splenomegaly. T cells not becoming cancerous in ALL. They do become cancerous here. Majority of the B cells are going to become cancerous. T cells are also becoming cancerous. That is why we say pre-B and pre-T ALL. No? सिंड्रोम कौन सा था? कौन सा सिंड्रोम रह गया मेरे भाई? इवान सिंड्रोम क्या है? ऑटोइम्यून हिमोलाइटिक एनीमिया एंड थ्रोम्बोसाइटोपेनिया. इवान सिंड्रोम CLL. So patients are going to be having massive splenomegaly, because of which they are going to be having a development of left upper quadrant discomfort. Left upper quadrant heaviness in the abdomen or discomfort in the abdomen. Because the cell of origin is a naive B cell. Naive B cell. ठीक है. जहां से राइज करेगा भाई वो तो इंपॉर्टेंट है ना. So this is what is going to be the clinical presentation of a patient. C1 patients are elderly patients, right? Middle-aged to elderly patients, and they are going to be having massive splenomegaly. Now, instead of writing the word massive splenomegaly, in the last 2 years, what they have done in the exam is patient was having left upper quadrant discomfort. Or the other thing which was given in the exam was patient was having a decrease in the appetite. Spleen is going to increase in the size, so it can compress the stomach. So patient doesn't feel like eating too much. So elderly patient, the size of spleen is increased, and there is going to be a decrease in the food intake of the patient, could be a pointer towards this kind of a cancer. However, please remember what is going to be done for this patient. When we are going to be looking at the peripheral smear of this patient is going to be having the presence of lots and lots of myeloid cells, myeloid precursor cells, eosinophils, basophils, band cells, neutrophil precursors. Myeloid cell precursors are present in a high number. Myeloid cell precursors are present in a high number. What they will also be making you a mention of the fact is sometimes patients can be having presence of basophilia plus eosinophilia. B and E, basophilia and eosinophilia. So left upper quadrant discomfort, massive splenomegaly, patient is going to be having a decreased appetite, patient having a weight loss, basophilia, eosinophilia, and cells in the peripheral smear, which are going to be having different morphological appearance. Cells having different morphological appearance appears to you, all cells have come in a party. We hope and pray you crack the exam well. We are going to be seeing all of you at cerebellum party as well. So that is what is going to be reminding you of college days. College girl appearance. कॉलेज गर्ल अपीयरेंस. सो कॉन्वेंट गर्ल अपीयरेंस जो भी आपकी हालत है, फोकस करके जस्ट सिंपल क्लोज, फोकस ऑन द एग्जाम. वंस यू क्रैक द एग्जाम, कॉलेज गर्ल अपीयरेंस. ऑल्सो गिवन द नेम ऑफ फ्लावर्स इन द गार्डन. Flowers in the garden appearance. Right? So every flower is unique. Every flower has its own speciality. Just like you and me. Each of us is special in our own ways. Never ever forget that. One exam, one profession, one branch, one failure, one good thing, one bad thing doesn't decide your life. It is much, much bigger than all of that. कांटों का भी महत्व होगा हर्ष कुमार जी. स्पोरोथ्रिक्स शेंकियाई हो तुम ही हो जो फंगस कराते हो, तुम ही हो जिसके अंदर वो एस्टेरॉयड शोमन बॉडी निकलती है. ठीक है. वैलेंटाइन डे डिजीज, गार्डनर्स डिजीज, रोज डिजीज तुम्हारे नाम पे ही बनी हुई है. तुम्ही ने एमसीक्यू बनवाया था वो. Right. So this is what is to be remembered. Translocation is important. 922. Please remember Philadelphia chromosome. Please remember the fusion gene BCR-ABL. Remember the presentation. Remember the peripheral smear finding. Of course, the examiners can talk about other important findings. नहीं, हर्ष कॉर्नर में क्राई नहीं करेगा. हर्ष के नाम में खुशी छुपी हुई है यार. वो खुश हो गया ये बात सुन के. आदित्य सूर्यवंशी, डबल डबल सूर्य आ गए तुम्हारे नाम में. आदित्य भी और सूर्यवंशी भी. हम तो भवरे हैं. भवरों को ही सिफिलिस और एचआईवी हो जाता है. ध्यान रखना, बच के रहना. चलो, जब हम बात कर रहे हैं यहाँ पे बोन मैरो एग्जामिनेशन 2023 bone marrow examination is what is going to be associated with the word pseudo Gaucher cell. This is the cell that we are referring to, pseudo Gaucher cell. इसके बाद बस ब्रेक ही ब्रेक, चिंता ना करो. Pseudo Gaucher cell which is going to be having the presence of a crumpled tissue paper appearance. Latent, वो रहना वाला, समय वाला. crumpled chromatin, crumpled tissue paper appearance. crumpled tissue paper appearance, pseudo Gaucher cell. एग्जाम का क्वेश्चन 2023 का. Where do we find the presence of true Gaucher cells? True Gaucher cells are a finding of Gaucher's disease. अरे यार, गुजरात समय रहना, ये सब आते थे हमारे कॉलेज में परफॉर्म करने. उस टाइम इतने फेमस नहीं थे, अभी तो थोड़े बड़े हो गए हैं. कोई बात नहीं. तुम जल्दी से मैमसी, सफदरजंग, एम्स आओ, तुम्हें सब मिल जाएंगे. आवश्यकता नहीं है. Gaucher's disease, glucocerebrosidase effect. So this was a separate question. So Gaucher cells are seen in case of glucocerebrosidase effect. Pseudo Gaucher cells, please remember, is seen in case of a cancer. The name of the cancer is what you need to remember as CML. Now, how will you confirm the diagnosis? स्क्रीनिंग टेस्ट कर सकते हो. स्क्रीनिंग टेस्ट की फाइंडिंग आ गई, पेरिफेरल स्मीयर फाइंडिंग. जाने से पहले रिवाइज कर जाओ. जाने से पहले रिवाइज कर जाओ. अपना कॉलेज फेमस कॉलेज, यूसीएमएस जिंदाबाद. When we are talking about the screening, the screening is done with the help of leukocytosis. Screening is done with the help of increase in the myeloid precursors. Screening is going to be done with the help of basophilia, eosinophilia. Screening is going to be done with the help of pseudo cells. But what is going to be seen over here is, if we talk about a score which is called as lab score is going to be decreased in these patients. What is going to be the investigation of choice? I have to show translocation 922. I have to show Philadelphia chromosome. I have to show both the genes coming together. And that can be done with the help of मछली जल की रानी है, जीवन उसका पानी है, fish technique. This is fluorescent in situ hybridization. Fluorescent in situ hybridization. समझ गए? फिश इश तो याद आ गया होगा ना देव बाबू? तो आपने याद रखना है that when you want to show the fusion of ABL and BCR, then you are going to be having the presence of a technique that is will show both the genes together. So one is given the right color, the second one is going to be given the green color, and when red and green come together, you are going to be having the presence of yellow color. So that is fish. B12 डिक्रीज नहीं होता भाई, B12 इंक्रीज हो रहा है अगर याद रखने की इच्छा ही है तो, right? So this is what you are going to be remembering over here. So patients are going to be having the investigation of choice as fish. So I want you to remember, what is the investigation of choice for ALL? Flow cytometry. What is the investigation of choice for confirmation of AML? Cytogenetic analysis. Investigation of choice for CLL. Flow cytometry. Investigation of choice of CML. Fish. राइट? फिश के साथ साथ आप क्या कर सकते हो, कभी कभी आप फिश करने के लिए आपको सैंपल चाहिए होता है, यू रिक्वायर एडिक्वेट नंबर ऑफ सेल्स. व्हेन एडिक्वेट नंबर ऑफ सेल्स आर नॉट देयर, यू कैन गो इन फॉर मिनिमल रेजिडुअल डिजीज इन इन्वेस्टिगेशन लाइक पीसीआर, पॉलीमरेज चेन रिएक्शन, पीसीआर. सो 2022 का क्वेश्चन जो आपको याद होगा, पेशेंट इज एल्डरली पेशेंट हैविंग स्प्लिनोमेगाली, हैविंग बेसोफिलिया, एओसिनोफिलिया. व्हाट इज द नेक्स्ट बेस्ट इन्वेस्टिगेशन टू कंफर्म द डायग्नोसिस? फिश एंड पीसीआर. फिश एंड पीसीआर, INICET. लैब स्कोर एक और डिजीज के अंदर भी डिक्रीज हो जाता है. लैब स्कोर, लैब स्कोर. पहली डिजीज कमाल कर दिया, कमाल, CML. सेकंड PNH, पता नहीं है, PNH. लैब स्कोर इज गोइंग टू बी डिक्रीज इन केस ऑफ CML एंड PNH. Right? So whenever somebody asks you that question, lab score is going to be decreased in, पता नहीं है, बट अब पता चल गया कमाल की डिजीज है CML. So that is what is going to be useful for answering the question which is going to be talking about reduced lab score. Cytogenetic analysis is the investigation of choice for AML, and one type of cytogenetic analysis which is fish technique is useful for making a diagnosis of CML. ये दोनों के दोनों ज्यादातर एसिम्प्टोमेटिक रहते हैं, ज्यादातर एसिम्प्टोमेटिक. हाँ जी रक्षिता जी, बस ब्रेक ले रहे हैं, चिंता मत करो. इससे पहले कि आप गाली वाली दे दो या अपना कूल लूज कर लो. लैब स्कोर, ल्यूकोसाइट अल्कलाइन फॉस्फेटेज. ल्यूकोसाइट अल्कलाइन फॉस्फेटेज एक प्रकार का एंजाइम जो रिलेटेड होता है व्हाइट ब्लड सेल्स के साथ. ल्यूकोसाइट अल्कलाइन फॉस्फेटेज. यहाँ पे जो प्रोटीन बनता है फ्यूजन जीन के कारण, क्या बनेगा? फ्यूजन जीन के कारण DNA के बाद mRNA बनेगा, mRNA के बाद बनेगा, दैट इज गोइंग टू बी समथिंग लाइक the protein. So the protein is having a weight of 210 kilodaltons. AML का साइटोजेनेटिक एनालिसिस ऐश्वर्या जी. ल्यूकोस्टेसिस कहीं पे भी दिख सकता है यार. ल्यूकोस्टेसिस दिखेगा द नंबर ऑफ सेल्स आर गोइंग टू बी वेरी हाई एंड दे आर रिस्पांसिबल फॉर स्लगिश सर्कुलेशन. फ्लो साइटोमेट्री इन्वेस्टिगेशन ऑफ चॉइस ALL के लिए और CLL के लिए. ALL CLL, ALL और CLL. ठीक है? सो दैट इज व्हाट यू नीड टू रिमेंबर ओवर हियर. ट्रीटमेंट ऑफ चॉइस फॉर CML, ये तो पता ही है आपको. CML का ट्रीटमेंट ऑफ चॉइस इमार्टिनिब. इमार्टिनिब के साथ में कॉन्सेप्ट ऑन्कोजीन एडिक्शन. इमार्टिनिब के साथ में ऑन्कोजीन एडिक्शन. ठीक है? दैट इज व्हाट वी नीड टू रिमेंबर. सो नाउ वी ब्रेक इन फॉर meals and we are going to be back after a gap of around 30 minutes or so. So hopefully 9:45 to 9:50. Bye bye. जिनकी मेस बंद हो गई है वो कभी जोमेटो का आनंद लेके देखें।
Mm.